Which of the following is the most likely mechanism of her amenorrhea? A 16-year-old girl comes to the office for a pre-participatory school sports examination. She plays on her high school soccer team and also frequently competes in local beauty pageants. The patient dietary limitations and exercises strenuously 2 hours a day. Onset of menses was at age 13, but her last menstrual period was 8 months ago. She otherwise feels well. Her height is 165 cm and her weight is 45.3 kg with a BMI of 16.6. Physical examination shows a pale and thin girl with fine hair around her trunk, but the remainder is otherwise normal. Urine pregnancy test is negative. Which of the following is the most likely mechanism? So, who wants to take it? Hello, guys.
Yes, we are.
I can't. I'm on another interface, so I might not really be seeing when somebody raises up their hand. But yeah, I can go on.
Between C and E, but I think it's C. I'll go for C.
Okay.
Hypothalamic suppression.
Okay. Yes, and that is actually correct. So, I want to know, like, what's your thought? Like, how did you arrive at the answer?
Okay, so this is a 16-year-old girl with BMI of 16.6. She's anorexic because 1. She's following a strict diet, 2. She's exercising strenuously, and 3. Her BMI is less than 18.5. She's anorexic. On her physical examination, she's pale, thin, and has fine hair around her trunk. Patients that are anorexic have anorexia nervosa, have a tendency to develop hypothalamic suppression, and this will decrease GnRH. GnRH will lead to decrease in LH and FSH. So she'll have problems with her period, so she'll have amenorrhea. That's why I'm going with option C. Thank you.
Exactly. Yeah.
The whole pathway is suppressed.
Exactly. So that's the clincher there, right? This her physique, right? The way they described her BMI, which is less than the normal, which is around like 18.5 to like yeah, I think like 23 or so. So this her BMI is really low. So this low BMI, and then her last menstrual period was 8 months ago. Someone that is not pregnant. Do you understand? You know that the GnRH pathway is being suppressed. Now, this can also come in the form of an arrow questions, right? Where you had your GnRH, they'll put up or down. You know your GnRH is going to go down. Your estrogen up or down. You know your estrogen is going to go down too, right? Then another thing that these patients can also present with, she might be having osteoporotic fractures. You understand? You look like a 16-year-old girl. Why are you having why are you having this fracture? Right? Yes, that's because of her low estrogen level, which will predispose her to osteoporotic or fragility fracture. Yes. Okay. This. I wanted to put on anatomy face. Okay, yeah. All right. Failure of which of the following embryologic processes is most likely responsible for this patient's lesion? A 13-year-old boy is brought to the clinic due to progressive difficulty with breathing, hoarseness, and dysphagia. The symptoms began insidiously 6 months ago, but have rapidly become worse in the last 4 weeks. The patient has no associated skin rash, pharyngeal pain, fever, weight loss, or loss of appetite. Medical history is unremarkable, and the patient takes no medications. Is up to date on scheduled vaccination, patient's parents and siblings have no history of significant health problems. Vital signs are normal, and he is at the 70th percentile for height and weight. Oropharyngeal examination reveals a large red lingual mass. The patient subsequently undergoes excision of the mass. This pathological proliferation of the recovered tissue is shown in the image below. Failure of one of the following embryologic processes is most likely responsible for this patient's lesion. So who
Is
wants
that
to
migration? Because you
Migration.
said that the lingual area.
Okay. But then with migration, absolutely. Yes. So this oropharyngeal examination here for this question is a very big point.
Dr. Linda, you're sounding far away.
Yeah. I was going to say
You
the
said I'm
same thing. Your
sounding
voice
what?
seems very distant. Your voice is distant.
Apart from
So
that,
it's
it's
kind of.
breaking.
Oh, wait, let me change.
I think it's
Can
breaking.
you hear me better now? Can you hear me better now?
Yes.
Yes.
Okay. So I was saying that this oropharyngeal examination, which reveals a large red lingual mass, is a big point in in nailing the pathology, what it is, right? And then also, if you can use this histology, it is good too, right? If you've come across this histology before now, because let's say you've not come across this histology, you might be like, what's this thing? What I don't really understand this, right? But with this, the clinical vignette, this oropharyngeal examination, it will clue you into what the answer is. Yes, it's failure of migration. You know when the thyroid gland develops, it's supposed to migrate. So anywhere along the path of migration from the floor of the tongue, right? Anywhere along that migratory route, it's arrest.
We can't hear you, ma.
Hello? Can you hear me now?
Yes, no, but after a while, just feels like you're distant.
Okay, so Dr. Chinyere, I don't know if you are close to your sister.
Yes, I am. Okay, please just let me know anytime my voice comes distant, okay?
Like right now, as you're talking, it keeps going back and forth.
Oh, really? Why? Can you hear me now?
Yeah.
Maybe if you're using a headset or something.
No, I'm not. I'm not using a headset. But is it better now?
Yeah.
Okay. So I was saying, right, the thyroid gland develops at the root of the tongue, right? So from there it descends to its position, right? So anywhere along this route of descent, it can be arrested, right? So that failure of migration, when it fails to migrate, yes, so you cannot have it in any of those locations. And that's what we have in this histology. If like now you've come across this histology, you know, oh, okay, the thyroid gland looks a little bit like kind of like you're looking at heart cells, right? So if you can master this histology, that would be fine. But if you cannot master it yet, you can still make out what is going on with the examination they've given here. Okay. And wherever the thyroid gland is now arrested, you can now have compressive symptoms, like you have this patient having breathing, difficulty with breathing, hoarseness of voice, and the dysphagia. All right. Which of the following is the most likely to develop in this patient? A 22-year-old man comes to the office for evaluation of a neck mass. Excuse me. lower neck 6 months before, and it has progressively enlarged since that time. Patients have had no changes in weight and otherwise feels well. Medical history is notable only for seasonal allergies, and he takes no medications. Physical examination shows a 2 cl blood in the right lobe of the thyroid. There are multiple 4 to 8 millimeter soft pupils on the lips and tongues. The arms and exceeds his height, and patient has long fingers. Serum calcitonin levels are elevated. The following is most likely to develop in this patient.
Episodic headache. I'll go with headache because I think this patient has meant to be because meant to be he has these soft pupils on the lips and tongue, which can go for the mucosa neuromas, and the arm span exceeding his height, and the patient having long fingers looks like muffinoid habitus. So it looks like it meant to be. So I'll go with pheochromocytoma, which comes with episodic headache.
Correct. So so you notice that when we read, we just try to cram men 2, men 1, the pituitary, the parathyroid, and pancreatic tumors, right? Men 2B, men 2A. Do you understand? So now the thing is, when you have all those these things, those classifications, what you have to bear in mind is that they will not just come and tell you maybe the men 2B, they have a parathyroid this thing, tumors, or the muffinoid this thing, physique. They will actually describe it. Do you understand? So it's with those descriptions that we use to like make out your answer, right? So like that the men 2B, you have your parathyroid with tumors, you have the muffinoid habitus, this thing, mucosa neuromas, like they described here. You can see that the patient had these pupils on the lips and the tongue. You also have this pillary thyroid carcinoma. Please, right here, they mentioned the serum calcitonin levels are elevated, right? Because that is what you see in your papillary thyroid cancer, right? And then you now have your pheochromocytoma. So, and the pheochromocytoma can present with the episodic headache. So, I don't know, very soon, the next maybe 5 minutes, I'll be giving you guys a break. I don't know how many minutes break do you people like to take?
Yeah, maybe 10 minutes, as long as we finish the question you mapped out for us.
Okay, are you guys good with the 10 minutes break? Hello? Can you people hear me? Can you hear me?
We can hear you. We can hear you.
It's okay. It's okay.
Okay, all right. Let's take this one. Then
Better than 5.
Which of the following is the most likely cause of this patient's symptoms? A 43-year-old woman comes to the office due to episodic confusion, blurred vision, tremors, and sweating. The episodes have increased in intensity in the past few months and seems to occur anytime during the day. Her symptoms are relieved by drinking orange juice. During a recent episode, the patient's blood glucose level was 32 milligrams per dl as measured by her husband's home glucose meter. Medical history includes major depression and irritable bowel syndrome. Laboratory studies performed during the next episode of symptoms showed the following results: glucose 35 milligrams per dl, insulin 18. The normal is usually less than 3. The C-peptide level is 4.01. The normal is usually less than 0.6. Which of the following is the most likely cause of this patient's symptoms?
Is it glucagonoma?
Sulfonylurea.
I would like anybody that gives an answer, please. I'd like to know your train of thought. Like, how did you arrive at your answer, please? Whether it's right or wrong, I just want to let's pick up from there, please.
Okay, the glucose is 35, which is low, like hypoglycemia. Then the insulin is 18, it's high. Then C-peptide, it's also high. So I feel it's something that is endogenous that is secreting the two of them, because the insulin and C-peptide like goes hand in hand. If insulin it's being secreted, C-peptide will also be secreted, I guess.
So which answer are you going with?
I feel like it's a tumor or something.
Okay, there are tumors. There are three tumors here. So which one? What's your answer? There are options A, B, C, D, E. Feel free, no judgment. Just pick your answer. We're all here to learn, okay?
E.
E, VIP secreting tumor. Okay. Okay, thank you. So who else has another opinion?
I have B. How about J? Alpha cell tumor, glucagonoma.
Okay. What's your line of thought, please?
Our symptoms are relieved drinking orange juice. Then also because the C-peptide is abnormally high, and the insulin is also high. So I was thinking probably it might be due to maybe a tumor secreting maybe glucagon.
Okay. Thank you, doctor.
Can I say something? Okay, let me say something.
Okay.
I think probably, the insulin and the C-peptide, they are both on the high side, and the patient is having hypoglycemia. So it may sound to be like a tumor, but it's not showing here. We are not seeing anything tumor, but I feel probably the sulfonylurea used, because one of the mechanism of action of sulfonylureas is to increase the release of insulin. And we know that when insulin is released, C-peptide is also going to be released. And so that would really differentiate between, are we giving just insulin alone? Because if we're giving insulin alone, we won't see C-peptide. But anything that will increase the release of insulin will also increase the release of C-peptide. So I feel the answer is sulfonylurea use.
Okay, I think we'll wrap it up with this. Thank you. So the answer is actually sulfonylurea use, right?
Okay.
So, like the last doctor made mention, you were all correct, like mentioning the high insulin and C-peptide, and when you produce insulin, right? The pro-insulin, the C-peptide is cleaved off of the pro-insulin, right? So therefore, C-peptide goes hand in hand with endogenous insulin, right? So whenever you see a patient having let's say this thing, hypoglycemia, right? And you're suspecting like insulin overdose, right? You now ask yourself, is it exogenous use of excessive insulin, or is it endogenous insulin production, right? Now, only thing that will separate exogenous insulin use and is this C-peptide level value, right? Because your C-peptide is cleaved only from the endogenous insulin. You have to go and look at your C-peptide level. Is it normal or is it high? If this C-peptide level is high, you know that it is an endogenous insulin. Therefore, you now go to your option, now start asking yourself, what will cause an increased production of endogenous insulin. So it's either going to be an insulinoma, right, or a sulfonylurea drug use, or sometimes, assuming they didn't put sulfonylurea here, they could have put all these GLP, glucagon-like peptide, all those incretins, all those things they call incretins that cause increased production of endogenous insulin, right? So for this alpha cell tumor, the alpha cell tumor is glucagonoma, right? So your glucagonoma will not cause an increase in insulin production, right? Then your this thing, insulin administration. This insulin administration is exogenous insulin, right? One, it will cause the increased level of the insulin to produce all those hypoglycemia, but your C-peptide level will be normal. Do you understand? So the only thing that clinches this answer now is this C-peptide level. See, it is 4.0, whereas normal is less than 0.6.
But Dr. Linda, is there anything showing that this patient is taking sulfonylurea drugs?
So
From the question.
Yeah, from the question, that's the thing, right? The question here, it may not give you the whole picture. Do you understand? Sometimes in the exam, you will not get the whole picture, but it's now for you to now use your the knowledge you have gathered and the concept that you know that insulin, endogenous insulin, and C-peptide level goes hand in hand. Whenever you're seeing your C-peptide level increase, your thoughts should be streamlined. This has to do with increased endogenous insulin, whether they wrote it there or not. Whether they told you the patient or he's doing
Can I say something?
Yeah, go ahead.
Okay, I think from the question that you have a clincher that actually show that you might be using. Because sorry, I'm driving, so my get a little noisy. The woman is depressed. There's a history of depression. So when you put it together with the knowledge, so somebody that is depressed, there's high chances of committing suicide. So she could be taken into commit suicide. And secondly, the hypoglycemic is episodic. It's not always. It happens. So that means anytime she takes the drug, that's when she has hypoglycemia. Then, secondly, now to show that she has access to the drugs, the husband has diabetics because it's her husband glucometer that was used to take her this sugar level. So from all those, when you put them together with the knowledge, you actually see that dog actually likely taking some years.
Oh, okay. Yeah, because I was wondering where is the diabetic history. Oh, okay.
She has access to the sulfonylurea that she knows to use the drugs. Yeah. Okay. Okay, we've done how many questions now? 2 or is it 3? We'll be going for 10 minutes break. So we'll be back by the next 10 minutes. Okay.
All right.
Okay, thank you guys. From which of the following structures is this mass most likely derived? A 7-year-old boy is being evaluated for growth retardation. Brain MRI shows a 4 cm multi-loculated cystic supracellular lesion, which is bulging into the floor of the third ventricle and the base of the brain. Calcifications are present. From which of the following structures is this mass most likely derived? Does anyone want to help us with the answer?
I don't really know the answer, but calcifications, I may be thinking of Samoma bodies.
Oh, okay. So,
So maybe a primary follicular cancer, follicular thyroid cancer.
I would actually want you to like look at the whole vignette. Consider the gender or the age of your patient. Consider the what your patient is presenting with. What is the presenting complaint of this patient, right? And also the brain MRI.
What would be the remnant of the Racke pouch? Something to do with the pituitary?
So what? Okay, go ahead.
The mass compressing on the hypothalamus, then affecting the growth hormone. How do I connect it?
Yes.
Can it be
Okay.
crenopharyngioma?
Yeah, that's what it is because of the calcification.
Right. So I think B is the right answer.
Yes. So your patient is presenting with growth retardation, right? So this presentation of growth retardation will tell you that something is happening to the growth hormone for some reason. Something is interfering with growth hormone release, production, something along that axis, right? So you're going to be asking yourself, this growth hormone, which part of pituitary produces your growth hormone, right? I mean, like, what is responsible for this release of your growth hormone, right? And then you can also see that the description of this of the lesion, right? They're telling you if there is calcifications. They're telling you is multi-loculated cystic. Look at the location. Bulging into the third ventricle and base of the brain, right? Yeah. So that's, and the age of this patient. This is a young child. You know that craniopharyngioma is common in younger children and is derived from this. This Racke pouch is what is responsible for giving rise to your anterior your adenohypophysis, which is your anterior pituitary, right? Okay. And you know in your anterior pituitary, that is where you have those cells, and where you have your basophilic cells and your acidophilic cells, right? Where your acidophilic, where you have your growth hormone and your prolactin, right? And your this thing, your
TSH and others.
Is it flat B?
flat B, yeah, is your
B flat.
basophilic. Yeah, the flat B is your basophilic cells, where you have your FSH, your LAH, your ACTH, right, and your TSH. Then your this thing, your acidophilic is not the one they call the parental guidance or GP, yeah, where you have your prolactin and your growth hormone. Yeah. Okay, that's your anterior pituitary, or they call it adenohypophysis. So it's still the same thing. So right, so their derivation is from this remnant of this Racke's pouch, right? And craniopharyngioma is also a tumor, a childhood tumor, as also develops from that same origin, that same remnant, this Racke's pouch. You understand? Okay. So let's take the next one. Okay, I think we've taken this one, the BMI girl. Yes.
Yeah.
Yes, we have. Okay, so let's take this one. Which of the following is the most likely diagnosis? A 61-year-old woman comes to the office due to a neck lump. She is otherwise in good health and has no other symptoms. Temperature is 36.7. blood pressure is 115/70, and pulse is 78. On physical examination, there is a non-tender, firm, I think this should be firm, I don't know what happened to the F. This should be a firm nodule in the left lobe of the thyroid. Laboratory results shows a normal serum TSH level. Thyroid ultrasonography reveals a 2 cm hypoechoic thyroid nodule with increased central blood flow. Fine needle aspiration biopsy shows cluster of cells with large overlapping nuclei containing finely dispersed chromatin. Numerous intranuclear inclusion bodies and groups are also seen. Which of the following is the most likely diagnosis?
I think it's papillary.
Papillary.
Antibodies that they're trying to describe.
Well,
Papillary trying to describe the open antibodies.
Okay. So what is this description of these orphan antibodies?
Cluster of cells with large overlapping nuclei.
Exactly, with finely dispersed chromatin. Yes. Yes. So that is the description. Yes. So once you see that that description, you know they're talking about this thing, the papillary carcinoma. Okay. And okay, what of if you were medullary carcinoma? What can clue you into medullary carcinoma?
Calcitonin and the rest.
the Congo red.
Congo red stain.
Okay. Then your follicular carcinoma.
The invasion.
Okay.
Invade the capsules.
Okay. What of your anaplastic carcinoma?
You see undifferentiated cells.
Giant cells.
Okay, absolutely beautiful, beautiful. So which of these thyroid carcinomas is associated with a childhood radiation exposure?
Papillary.
Okay, all right. Okay. All right, let's take this one. Compared to metformin, this new therapy is most likely to increase the risk of which of the following? A 67-year-old woman comes to the office for follow-up of type 2 diabetes mellitus. She was diagnosed with diabetes 6 months ago. Lifestyle modifications was initially advised, but the patient had no significant glycemic improvements. 1 month ago, the patient was started on metformin. However, she has been experiencing abdominal discomfort and diarrhea attributed to the therapy. She has no other medical conditions. BMI is 28. Physical examination is unremarkable. Laboratory tests show hemoglobin A1C is 8.2%. After further discussion and with medication affordability taken into consideration, metformin is discontinued and glipizide is prescribed. Compared to metformin, this new therapy is most likely to increase the risk of which of the following?
Symptomatic
I
hypoglycemia.
think this
Sulfonylurea.
is insulin. Is it insulin secretagogue?
Secretagogue, yes,
Yeah,
sulfonylurea.
symptomatic hypoglycemia.
Okay, why is it symptomatic hypoglycemia and not any other of these conditions or any of these other options?
D and E of metformin complete side effects. B2. Pancreatic is, I think it's GPP4.
Okay.
Then
I
option
don't think
E
it's metformin.
No, G is the
Gliflozin,
Yes,
GLGL2.
the flow guys them.
yes, low guys, yes.
Okay, so actually, like I know you guys must have heard this before. Like all these test taking techniques, it's either you know the answer straightforward and you go and pick it, or you can use elimination method, right? Okay, you know you're looking at glipizide. What is glipizide? Glipizide is a sulfonylurea drug, right? So you know what sulfonylureas, what they do not understand. Like you know that they're not the ones that give you renal dysfunction. That one is the metformin. You know they are not the ones that will give you your acute pancreatitis, right? You know they are not the ones with the vitamin B12 deficiency. You know they are not the ones with the vulvovaginal candidiasis. So therefore, you're just left with symptomatic hypoglycemia, right? You pick your answer, right? Or sometimes you know that glipizide, this is what it does. Sulfonylureas, they increase endogenous insulin secretion. Therefore, there is a high risk of symptomatic hypoglycemia. Just pick your answer straightforward, right? Okay, so that is actually correct. It's symptomatic hypoglycemia. Okay. So apart from these sulfonylureas, right, that cause increase in endogenous insulin, which other drugs that they use for diabetes type 2 causes increase in endogenous insulin?
Meglitine, right?
Okay. Is that all? There are two more that I'm trying to. I want to hear. I know you guys know them, but I think maybe you guys are associating them with another thing. But they are also under the group of those that can cause endogenous insulin release.
GLP-1,
And what? GLP and what?
DPP-4
That one.
inhibitors, amylin analogs.
Yes, the GLP this thing analogs, and then the DPP-4 inhibitors. Yes, beautiful. Yes, yes. Now these two, the GLP analogs and the DPP-4 inhibitors, right? The two of them kind of, their actions are kind of similar, right? In the sense that if you understand what GLP does, right, you will not understand why they use DPP-4 inhibitors, right? So kind of similar. This is why in your first aid you see that both of them have almost the same mechanism of action and same what they call it side effects too. Do you understand? Because that GLP analog is glucagon-like this thing, peptide analog, right? It will increase endogenous insulin secretion, right? Now, that GLP-1 analog, what breaks it down is what they call a DPP-4, right? So this DPP-4 is supposed to break down this GLP. Therefore, it makes sense for you to now have a DPP-4 inhibitor that will not inhibit that DPP-4, therefore allowing your GLP analog to act very well. You understand? So both of them have the same, almost same similar mechanism of action, same side effects too. And then both of them will increase endogenous insulin secretion. And then actually your GLP analog and this, I think, glucose insulinotropic hormone, both of them are called incretins. You guys have heard of incretins, right?
Yeah.
That increase this thing level of insulin when you give an oral dose of this thing of let's say even if it's carbohydrate or even sometimes fatty meals, when it's given orally and not intravenously. And these things can come as a graph, right? They will show you the graph, to have a graphical representation that this patient was given so milligram of glucose food, maybe high in carbohydrate or just glucose straight up, right? then within how many minutes you can see that the level of insulin also in the patient's blood has risen as like exponentially. They will not ask you what is responsible for this phenomenon. Right there, they can just put your incretins, or they can just break them down and put them as your glucagon-like peptide, or your this thing. The other one, the glucose insulinotropic hormone. All right, let's move. Okay. Which of the following is the most likely cause of this patient's hyponatremia? A 45-year-old man comes to the emergency department after experiencing a sudden onset headache with brief loss of consciousness while walking in his yard. CT scan of the brain reveals blood in the basal system from a ruptured intracranial aneurysm. The patient is hospitalized and endovascular coiling of the aneurysm is performed. Over the next several days, his symptoms gradually improve, but the patient develops worsening hyponatremia. Which of the following is the most likely cause of this patient's hyponatremia? Does anyone want to help us with this?
Could it be related to SIADH? Because of the
So
head
what,
trauma?
so what are you thinking? If you're thinking of SIADH, put us through with your line of thought.
Or maybe increase antidiuretic hormone secretion.
I'm thinking it's E, the stress.
Cortisol.
Yeah, the cortisol because of the surgery. So a few days after the procedure, so the cortisol rises and then can deplete the sodium. I'm trying to connect it to sodium, but I think it has to do with stress-induced excessive cortisol level. Yeah.
So you're saying the cortisol is responsible for the worsening of the hyponatremia?
Could it be defective central thirst regulation? Like patients could not control how they drink water because they can't regulate their thirst centers. I'm just thinking aloud. I don't know. It looks reasonable to me.
I think it's D because of the head trauma.
Yeah,
And,
I think it's D too.
Yeah.
Okay, thank you all for your thoughts. The answer is actually D, right? So you can see that this patient had from a ruptured intracranial aneurysm, right? This patient had like he had a head trauma. Remember, when you have head trauma, there is some things that come with that head trauma. An example of that includes this SIADH, that syndrome of inappropriate ADH secretion. So when you have this syndrome of inappropriate ADH secretion, what happens? There is excessive antidiuretic hormone secretion. So what does your antidiuretic hormone, what's the effect you now have, right? Antidiuretic, therefore, is against diuresis, which is water loss. So you're going to have excessive retention of water. What would this excessive retention of water do? It will now cause hyponatremia. It will dilute the sodium. So there will be excess water relative to the serum sodium. Do you understand? So you now have this picture of hyponatremia. Okay. For the impaired renal concentrating ability, that should be the diabetes insipidus, right? So that is that's a picture you can get when you have when there is use of this drug lithium for bipolar disorder, right? Patients present with this lithium toxicity, which can give this impaired renal concentrating ability, right? Then the defective central test regulation. It says test regulation, right? So this, you'll be thinking of more like lesions to the hypothalamic nuclei. So which nuclei in the hypothalamus is responsible for controlling the test? There's a mnemonic they call SAD fox.
Yeah.
Okay. So for the defective central test regulation, it's more of hypothalamic nuclei lesion, right? So that is not what this patient is having. Inadequate dietary sodium intake, of course, no, that is not that's not the picture that was painted here, right? There's stress-induced excessive cortisol level. No, this patient, there is no evidence of like stress causing this thing. And excessive cortisol, what kind of effect are you going to be seeing with when you have cortisol level?
High blood pressure.
There is no picture of that. Remember, you said cortisol can also activate your has a weak mineralocorticoid effect, right? Yes. So yeah. Hello.
Yeah.
So cortisol has a weak mineralocorticoid effect. So what does the mineralocorticoid do? Aldosterone. They cause sodium and water retention, right? And potassium excretion. So you're supposed to be having a picture of hypertension here, which is not what we're having with this patient, right? But we're just having just a picture of hyponatremia. So that rules out this stress-induced excessive cortisol level and leaves us with this D, which is the increased antidiuretic hormone secretion. Okay. Let's move. Okay. Excuse me. Which of the following is the most likely mechanism for this patient's gynecomastia? A 38-year-old man comes to the office with headaches, loss of libido, and erectile dysfunction for the last 3 months. The patient has no chronic medical conditions and takes no prescription or over-the-counter medications. He does not use tobacco, alcohol, or illicit drugs. Vital signs are normal. The examination is notable for peripheral vision loss, bilateral gynecomastia, soft testes without masses. Laboratory evaluation show normal serum prolactin, normal beta HCG, low serum LH, and low serum testosterone. Which of the following is the most likely mechanism for this patient's gynecomastia? Can someone help us with this? Hello, guys. Don't be afraid to contribute. So whether it's right or wrong, just air out your opinion, say what you're thinking. We'll take it from there, whether it's right or wrong.
Is it E?
Okay, why are you thinking of E? Please, any answer you're thinking of, please just let us know why you think that is the answer, please. Like we said, no judgment. We are here to learn, please.
I'm looking at E as well, but honestly, I can't really please put it together.
Put together.
Yes.
Does this patient?
Let me say my thought. The pituitary, the vision loss. I'm thinking some tumor, pituitary tumor or something. Some peripheral vision loss, bilateral. And then the prolactin, serum prolactin is normal. I don't know.
Okay, let me try.
Yeah, I'm thinking a tumor too in the pituitary gland because of the bitemporal hemianopia and the headaches. So I
Yeah.
think it's a tumor that is affecting probably the follicular stimulating hormone and LH.
Okay. Any other opinion?
I'm thinking maybe a pituitary tumor, like maybe a pituitary adenoma or something, and I know that it could also be because of maybe like this aromatization of the testosterone to estrogen. I know that I think beta HCG, LH, FSH, they have the same alpha receptor. So yeah, something. So I can't really put my
But
thoughts.
if we're thinking of the tumor, shouldn't the serum prolactin be elevated? Should it be elevated? But it says a normal serum prolactin. Can this really be an enzymatic defect in the testosterone synthesis? Maybe what's this enzyme that does the peripheral conversion? 5-alpha reductase. I don't know, just thinking now. And the test is without mass. So
Just in addition to what the other doctor said about prolactin, let's remember that there's some non-prolactin secreting tumors as well. So this could be one of them. And that might be the reason why the prolactin is normal. It could still be pituitary lesion, but the prolactin is normal if it's a non-prolactin secreting one.
Somebody's somebody needs to make.
Dr. Linda. It's Dr. Linda's background.
Okay. So the answer we using. Hello, guys. Hello. Hello.
We can hear you.
We've been saying our thoughts since.
Yeah, I heard you. So what's the final? Because there's a lot of options going on here. So what are we choosing?
E, maybe.
Okay. Okay. I agree with you too. Because if you look at this vignette, right, this patient has been having headache, loss of libido and erectile dysfunction, right? And the examination, they say, is notable for bilateral gynecomastia with soft testes without masses, right? And then the lab work here, you can see that the patient has low serum testosterone, right? So you now ask yourself, what could be as a male patient now, right? It's assumed that this patient is supposed to have like normal testosterone level, right? But there is low testosterone. So that means you'll be thinking about maybe something is going on with the GnRH axis, or if that axis is okay, the testosterone that is being produced, right? What maybe is being changed to something else, right? And there is this pathway where there is aromatization of your this testosterone to estrogen, and that will give rise to a lot of estrogen, and the patient can now present with the gynecomastia, right? But what they call it, if this other presentation of normal serum prolactin, normal beta HCG should rule out let's say kind of like a tumor from this thing. from the anterior pituitary, right? So yeah, I think that should be the best bet. This persistent aromatization of the adrenal estrogen, right? Now, another trick you can have with this question is there's this androgen, right? From the this thing adrenal. There's one that is produced only by the adrenal. I think the estrone, the one, there are different types of estrogen, right? You can have the estradiol, estratriol, right? The one that has the T, and then the estrone. So there's one that is specific to the this thing, to the adrenals, right? So sometimes in option, if you can see that one, I think is the RONE. That's the one that is specific to the adrenals, in case if they're trying to be specific on the type of estrogen you have that is being aromatized. Okay.
Yeah, Dr. Linda, come again. So if, yes, I chose the answer E, aromatization, but I really don't quite know how to connect it to the visual and gynecomastia, bilateral. So since there's no pituitary defect, there's nothing happening to the pituitary gland, what is the cause of it? What is the cause of this excess testosterone being converted to estrogen?
Okay, the question comes with. So, like I said, it could be an adrenal tumor, right? So this patient will have an adrenal tumor, and like I said, those adrenal tumors, they produce what they call it estrogen. There's like 3 different types of estrogen that you can have, right? You have the estradiol, the estratriol, and the estrone, the one that has the RONE, right? Yeah. So I think that estrone comes from the adrenal, right? So in case of an adrenal an adrenal tumor, you can have this aromatization of that aromatization into that estrone, right? And estrogen is responsible for the development of the breast tissues, right? So that can lead to this patient having this bilateral gynecomastia. Okay. All right. So, okay. Which of the following is the major contributor to bone loss in this patient? A 45-year-old woman is evaluated 2 weeks after she fractured her left radius during a fall from standing height. 2 months previously, she passed a renal stone. There is no family history of osteoporosis or hypercalcemia. Physical examination is unremarkable. Serum laboratory results are as follows: calcium 11.3, phosphorus 2.4, creatinine. Creatinine is 1.0, albumin is 4.1, parathyroid hormone is 75. So the normal is usually 10 to 65, right? So the bone density testing performed using dual energy X-ray absorptiometry reveals osteoporosis. Which of the following is the major contributor to bone loss in this patient? Some?
I'll go with option C. This is because I'm not sure if it's right, but I'm going to give my thought. This is a 45-year-old woman that has she presented with osteoporosis on bone density testing. So it's known that a patient that's going advancing age, they have low levels of estrogen. So I think maybe the estrogen is inhibiting Because normally estrogen causes slow bone remodeling. So I'm going to think that the bone remodeling, which is done by the osteoblasts, is not working as much as it used to when she was younger. So there will be inhibition of her osteoblast differentiation. That's why I'm going with option C. I'm not sure. That's what I think.
I think I want to go with option C.
I'll go with option B because decreased bone formation due to excessive loss of calcium in urine. Because from her history, she passed a renal stone, meaning that she has hypercalciuria, I think.
Yeah, I'm with you.
So that would contribute to maybe she's losing calcium in urine. And
decreased bone formation due to so she's excess calcium. This is
What about option E?
this is primary hyperparathyroidism. Decreased bone formation due to excess loss of calcium.
Sorry, I also wanted to add something. I just kind of feel that I don't know if they're looking at the angle as well that this lady, although she's 45 though, but the fact that she has a fractured radius and they said she has osteoporosis, I don't know whether she probably has probably a reason that's causing her to causing her to have osteoporosis at this time, like
We're not hearing you.
an ovarian,
Can't hear you well.
maybe a primary ovarian failure or something. And can you hear me now? Can you hear me now? So if she does have that and she's having osteoporosis, I'm just wondering if this has anything to do with the option E. I feel if her estrogen levels are low, it would ultimately cause her osteoprotegerine to be low. And osteoprotegerine is what would obviously cover the osteoblasts so that they don't interact with the osteoclasts. But if her level of osteoprotegerine is low, then you have the ratio of the osteoblast receptor to be higher. And I feel that there will then be more interaction with the osteoclast because differentiation and thereby causing osteoclastic activity. So that's why I was considering E, but I'm not sure of this paracrine that is written there. That's my only problem. I don't know what that means.
Okay. So these patients, right, you can see that the parathyroid hormone level is high. That's like is 75 and the normal is 10 to 65, right? So that means this is a case of this thing, hyperparathyroidism, right? So that means there's excessive level of this thing, parathyroid hormone. Now you now ask yourself, what does parathyroid hormone, what effect does your parathyroid hormone produce, right? We know that parathyroid hormone will actually cause, okay, for the way I usually take it is I take it that the parathyroid hormone receptor, right, excuse me, is on the osteoblast, right? So that means your parathyroid hormone can stimulate your osteoblast, right? So, but now in this patient, parathyroid hormone is high, and yet the patient is still having symptoms of osteoporosis. That is, so therefore, you know that something is wrong along the line, right? So therefore, that means this, and then you're having that the patient is also presenting with stone. Renal stone will also key you into the picture of this thing. What they call it, will also key you into the picture of there is a lot of calcium, right? And then look at the calcium level too. This calcium level is high for this patient, right? So now in that case, we said that the parathyroid hormone has a receptor on your osteoblast, right? So I know there is in FA, there is this will I say a legendary diagram where you have the interaction of osteoblast and your osteoclast, right? You have that once you activate your osteoblast, your osteoblast will go and activate your, your osteoclast through that that rank and rank L this thing interaction, right? Now we said that the parathyroid hormone has a receptor on the osteoblast. That means, and it's high in this situation, that means it's going to be activating the osteoblast. So therefore, what will the osteoblast now do? The osteoblast will in turn go and activate the osteoclast. What will your osteoclast do? Your osteoclast, their problem, their name, you have to add according to their name, that like to class down, break down things, to cut down things now, they class down the bone. So therefore, they'll be classing down the bone. When they're classing down the bone, they're breaking down the bone. What happens to the bone? The bone becomes weak. This woman is not yet postmenopausal now, that we will say, okay, reduce estrogen. She's still 45 years, right? Rather, she's like very, very menopausal. Do you understand? So she's not supposed to be having this osteoporosis and fragility. What she had here is what they call fragility, fracture, like normal person now. At this age now, she's assuming she falls, she's supposed to get up and and do like nothing just happened, right? Yeah, but now she's experiencing what they call fragility fracture. That's fracture that you see in postmenopausal women. Fracture that occurs like from little trauma. Do you understand? So what is causing that? The bone is weak. Why is this bone weak? There is increased osteoclast activity. Why is this osteoclast acting too much now? Osteoblast is activating them. Why is osteoblast being activated? Parathyroid hormone that has a receptor on the osteoblast is tickling the osteoblast. Therefore, it's almost like a domino effect. This one will tickle this one will go touch this one touch this one. Do you understand? So therefore, our answer will be option E. Okay, which says increased bone resorption due to paracrine. Paracrine is like local, something that is happening locally. Stimulation of osteoclasts by osteoblast, which are stimulated by thyroid hormone. Did you get that?
Yeah. So that paracrine that actually threw me off anyway. So
renal stone kind of threw me off too.
So the renal stone just shows that there is hypercalcemia. Remember, what is the function of your thyroid hormone now? Thyroid hormone is like calcium is like his bestie. He always wants, to raise the level of calcium. So you've now raised the level of calcium. Okay, now so therefore there will not be renal stone. Do you get? Okay. Yeah. So urinary loss of calcium, right? I know with the renal stone, you think that there is excessive loss of calcium. But that is not enough to cause
Okay, so that takes B off. Okay.
Okay. Are we good with this?
So the answer is C?
E.
E for egg. E for egg. Did we get this explanation?
Yeah, I got it. It's so confusing with B. B for boy, but it's okay. I got it.
You say it's confusing with B. Let me look at B.
Because in an exam, because I didn't know what paracrine, so immediately I disregarded that answer, paracrine. I'm looking for something straightforward. I thought, okay, urine, and then the decreased bone formation, which is decreased osteoblast. But you're trying to put in osteoclast in it, which makes sense. Yeah. Osteoclast is the main problem here. Okay, thank you.
So the thing is, this decreased bone formation due to excessive loss of calcium in urine, even though with your renal stones shows that there is hypercalcemia. And when you think of hypercalcemia, therefore the kidneys, of course, are filtering a lot of calcium too, right? But this filtering of calcium in the urine is not enough. Is not significant to cause decreased bone formation. Do you understand?
Yeah.
Yeah.
I'm sorry, Dr. Linda, does that mean there's increased osteoblast?
Yes, of course. Yes, there is increased osteoblastic activity. That is why you have the word here, paracrine stimulation. It is your osteoblast that is doing this paracrine stimulation of osteoclast. So I tried to mention before, there is this legendary picture in UWorld where you have a relationship between the osteoclast and osteoblast. I wish I can draw here, where you have your rank and your rank L, right?
Yeah.
Where you have and then that's osteopetrogen, right? You know that your osteopetrogen comes and covers your rank L, right? So that it does not interact with the rank on the osteoclast, right? But when you have removal of this your osteopetrogen, you now have that the rank and the rank L are now open to like interact with each other. And when osteoblasts now interact with that osteoclast, it will now turn the osteoclast to an activated osteoclast. So in that picture, the osteoclast, before the interaction with osteoblast, it had like one nuclei, I think. So after that interaction, you will now see that it will now have so many nuclei. Do you understand? That shows it's now an activated osteoclast. So the basic point you have to bear in mind here is that your osteoclast has to be activated by interaction with your osteoblast. Do you understand? And that interaction is through that rank and rank L, right? The rank L on the osteoblast, your osteopetrogen covers it, right? And that is that's where your estrogen now comes in. That's where estrogen comes in. So estrogen upregulates the number of osteopetrogen. That is why young women, young girls that have a lot of estrogen, they don't have a lot of osteoclastic activity because estrogen will upregulate osteopetrogen. Osteopetrogen will cover an L, and then there will be no interaction of the osteoblast with osteoclast. It cannot activate the osteoclast. Do you understand? So there is no breakdown of bone. But when estrogen now is now low, you now have reduced osteopetrogen. Therefore, there cannot be interaction, right? And then your osteoclast can be activated and start breaking down. Then another thing that can happen is that this osteoblast too, that has the rank L with the osteopetrogen, has parathyroid hormone receptor on it too. Do you understand? So this parathyroid hormone, when in excess, can also go and activate its receptors on the osteoblast. It will keep activating the osteoblast. When you activate the osteoblast, this osteoblast will increase interaction with osteoclast, activate the osteoclast. This osteoclast will now go and between their function, which is to break down of bone, leading to osteoporosis. Do you get the picture? Hello? Am I still audible?
Yes.
Yeah, audible. We got it. Thank you.
Okay, we can move. Let me see. Okay, no, this cannot be the last question. Maybe just the last question here. Okay, we've done this one. Okay, let me just go back. We've done this one, 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 done this one. Okay, I think we need to do this one. Yes. So you have which of the following enzyme reaction steps is most likely to be disrupted in this patient? A 17-year-old girl is brought to the clinic due to irregular menses. Menarche was at age 1 and her cycles since then have been irregular, often with multiple months between menstrual periods. The patient also has had an increase in hair growth along her chest and face. Temperature is 37.3. Blood pressure is 1110/70. Pulse is 80. There are dark terminal hairs above the patient's upper lips and medullocystic acne across her forehead. Cardiopulmonary examination is normal. Sexual maturity rating, Tanner stage, is 5. Ultrasound examination of the pelvis reveals a normal uterus and ovaries. Electrolytes are normal. Other laboratory results are as follows. Testosterone serum level is 400 nanogram per dl, whereas the normal is 25.7, 25 to 75. 17 hydroxyprogesterone is 350 nanogram per dl, the normal is less than 200. Which of the following enzyme reaction step is most likely to be disrupted in these patients? Can somebody help us with this?
I think she has virilization. So everything is shunted to the reticulosa area. So it's going to be, what will be affected will be conversion of the progesterone to 11-deoxycorticosterone.
I think I have a difference of opinion that is C, ethanol conversion to 17 hydroxypregnane.
Yeah.
Am I wrong? No, maybe I am. Sorry.
Yeah, I think it's 17 as
17
well.
actually C. Yeah, C.
Yeah, see.
You see.
Okay, why are you going for C?
The question is asking us about the thing that's most disrupted, likely disrupted. That pathway is disrupted, so we're not getting androgen. Yeah.
You're not getting androgen?
We're not.
Excess of androgen.
Wait, excess of androgen. No.
I think I agree with the first person.
Can I comment? Yeah, it's 21 alpha hydroxylase.
I think conversion to 11 is disrupted. Yeah.
Question very well.
Yes.
Yeah, she has these dark terminal hairs, on the upper lip. That's like a mustache, Abby. That's what they call mustache. Like, what they call it mustache for you now. And then nodulocystic acne across her forehead. Right? Yes. So what answer are we going with now?
D. It's D. D. 21 alpha hydroxylase.
Yeah, D for dog.
D for dog,
right?
Yeah. Yes, D for dog.
Yeah. Absolutely. So this is still congenital adrenal hyperplasia, right? So in this situation now, you can see that this patient, she's a female, so she's presenting with signs and symptoms of this thing,
virilization.
Virilization, right? So that means there's a lot of production. There's a lot of production of this thing, androgen, right? So, it has to do with the pathway where you're having your this thing, progesterone being converted to 11-deoxycorticosterone. So that pathway is interrupted. So therefore, there's now shunting to excessive production of this thing, androgen.
Yeah.
Okay. Did someone raise up their hand?
That's our son.
I can't see the other interface. So, did somebody raise up their hand?
Yes, sir. It's our son.
It's Dr. Festus.
Oh, Dr. Festus, go ahead.
Dr. Linda, thank you so much. Thank you so much, everyone. Thanks for this beautiful answer and this beautiful question. Just to add to what you've all said about this question, so that you will get another gist here. There is something we call classical congenital adrenal hyperplasia. We also have what we call non-classical. I intentionally skipped that. It was intentional because I thought that would be more of step 2. But let me try to introduce you to it. There is nothing about it. There is no stuff there. Just look at the age. Because if you call something congenital, it should appear earlier. But this is 17-year-old. So that when you start discussing with those that think the concept academy is a joke, you should display some understanding. This 17-year-old is no more classical congenital adrenal hyperplasia. So you call this non-classical congenital adrenal hyperplasia. Now, with respect to non-classical, the only enzyme deficient that you talk about there is 21 hydroxylase. Never forget that. So in case you are giving that question, Once you look at the age, and you realize that this is 7-year-old, this is 8-year-old, this is 10-year-old, this is 15-year-old that is now coming down with this. Then now see which enzyme. Once you see that, go for 21 hydroxylase. They can put the other enzyme there. 11 can be there, but we won't go for that. The answer will be 21 hydroxylase. The next thing they will also give you is that which hormone is most likely to be elevated. Once you see that, for the non-classical, you go for 17-hydroxyprogesterone. That's the hormone they are most likely going to test. There is no any other hormone they are going to test. What they are testing here is the enzyme. So another question you can set from here is which hormone is most likely going to be elevated. They won't test testosterone. It's this 70-hydroxyprogesterone they will test. Do you get my point, everyone?
No, please take it again.
All right. When it comes to congenital adrenal hyperplasia, if you look at the name congenital, it should appear early, right? Right? Are you hearing me?
Yes.
Lovely. It should appear early. You now look at the question. You're already thinking towards congenital adrenal hyperplasia. You now check the age of the patient, and that age of the patient is more of someone that is old, not old like this is not a baby again. Do you get me? Maybe adolescent or someone that is more or less around even maybe more than 2, 3, 4, 5, 7 years. The typical ages you will see them give their adolescent age, and they now give you the picture. So if you see that, all of you will be thinking that this is from the analysis, this is congenital adrenal hyperplasia. You are actually correct. But what kind of congenital adrenal hyperplasia will this one be? You go for the non-classical. Do you get me? Non-classical or non-typical. Non-classical congenital adrenal hyperplasia. Do you get my point?
Yes.
Yes.
The classical one you will see just in the newborn baby, they are already seeing features. How come they didn't see anything in this patient until the patient is 17? Do you get me? So this is non-classical one. Now, which enzyme are they going to test? The only enzyme they will test, whether they are drunk or they are undrunk, is 21 hydroxylase. So if they do not test 21 hydroxylase, ignore that question. Drop the question and tell them that the question is not complete. That's number one. That's just a joke, but just to tell you that 21 hydroxylase is the main enzyme they will test. Which other concept can they test there? And that is this 17-hydroxyprogesterone. Anywhere you read it, and you are like, the age alone is giving it out. They are now asking that which molecule is likely to be elevated. The molecule they are most likely going to test is 17-hydroxyprogesterone. Do you get me? Note it. So all this testosterone they are giving here is because when 17-hydroxyprogesterone is high, so you know that the androgen pathway is already hyperactive, so testosterone production also will go up. But this is the main molecule, 17-hydroxyprogesterone, that they are most likely going to test or put in question. Do we all get it?
Yes, sir.
All right.
Yes, sir.
Okay.
So, sorry, please. So, what is our answer? Isn't D still?
Yes. Yes.
Okay.
So
Thank
why is not C is that C is what is causing the presentation. But look at the question. They're asking you what is disrupted. That means what is not working, what is blocked, which is this progesterone conversion to 11-deoxycorticosterone. Therefore, your 17 alpha hydroxylase will now be working in excess to produce this your 17 hydroxyprogenolone that will now give you a lot of androgen and now give you virilization, right? But the question is asking which pathway is disrupted, which is this progesterone conversion to 11-deoxycorticosterone. Okay. Are you okay? Can we move? Are we okay with this question?
Yes. So in other words, C will lead to D.
No, in other words, C is what is causing the presentation, is what is causing this virilization, is why the patient is having the pathway that is producing the excess androgen.
Okay,
It's just like
I said it backward. D will lead to C.
Yes, kind of.
Okay, thanks.
Yes. Or it's just like you have excess material, raw material. You're supposed to use it to produce D, right? You now find out that okay, the main the enzyme for that for D operation is not working. You be like, instead of wasting your substrates, now your materials, let you carry it and go to C pathway. Do you understand? Yeah. So it's now at that C pathway you're producing a lot of androgen in a female. So what will your androgen do? It will cause virilization for this female.
Yes.
Okay, so C is accumulating in some way.
Yes. Yes. So it's important to look at what they're asking you, the question. So because if they ask you now, well, which pathway is unregulated, right? Unregulated, that is which pathway is acting in excess. That is where your C will now come into play as your option. But the equation is disrupted. Disrupted means which pathway is absent, not working well. Do you understand? That is why our option, our answer is D.
Yes.
Okay. All right. We can move on. Okay, I think we've done this. The hyperparathyroidism. Yeah, we've done this persistent aromatization. We've done this. 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 Okay, I think that's our question. We've done this. Am I repeating questions with something? Let's take this. Which of the following changes are likely to occur following octreotide treatment in this patient? A 50-year-old man comes to the office following transsphenoidal resection of a growth hormone secreting pituitary adenoma. 3 months ago, the patient was diagnosed with acromegaly, MRI of the arm. Can somebody help me read this for a minute?
MRI of the pituitary showed a 14 mm cellular mass pressing on the optic chiasm and extending into the right cavernous sinus. The surgeon was able to only partially resect the pituitary mass because of the extension into the right cavernous sinus. Medical therapy for acromegaly with octreotide is planned. Which of the following changes are likely to occur following octreotide treatment in this patient?
All right. Who wants to take a go with it?
I'll go for A.
So the growth hormone level will fall. Insulin growth factor would also fall. Yeah, everything should reduce.
Yes.
Yeah. So I'll go for A too.
Okay. So why is this insulin-like growth factor 1 level also falling?
So the mechanism of action of growth hormone
Beautiful.
it will act through that factor. So because we are trying to antagonize the effect of the growth hormone using octreotide, it should, once the growth hormone is acting through that, it's going to automatically also reduce that because it's going to use that growth factor to execute its action.
Beautiful. You already answered this. You already answered it. So that was just extra English. So what you said there, that I wanted to know whether you had that in mind when you picked your answer, was that growth hormone is that most of its effect through this insulin-like growth factor 1. Do you understand? So most of these effects that growth hormone, the things that growth hormone does is that most of it does not directly come as, see me, this is growth hormone, I have come. It does it through this insulin-like growth factor 1. Do you understand? So therefore, if your growth hormone level is going to be falling, it means that your insulin-like growth factor 1 level 2 will also be falling. Yes, which is beautiful. Yeah. So this, I agree with option A. The answer is A. So this octreotide now will antagonize the effect of growth hormone. Therefore, the level of growth hormone will fall. Subsequently, this insulin-like growth factor level, factor 1 level will also fall. And then this adenoma size will actually fall too. Do you understand? Yeah, because there is no more growth of that adenoma. Yeah. So yeah, we're right. But so this octreotide now, what is it like? What kind of drug is it? What is it? And can you mention any other place you use octreotide?
It is a somatostatin analog.
Okay. What else? Like 2 common conditions you use octreotide.
Leukognoma too.
Vipoma.
Okay.
Leukogonoma.
Yeah. So actually, exactly. This octreotide, will I say na Sabine medicine or something like that. Like when you're in doubt, you can actually just pick it, right? It's a very versatile drug treatment for most tumors in GI and endo, right? Yes, you can use it for your carcinoid tumor, your leukognoma, your vipoma, right? Yeah.
And even non-esophageal varices. Yeah.
Yes, it has a very like a versatile use. Like it's hard to like really box it into one thing and say this is the only thing you use it for, right? Yeah. Okay, so we're good with this, right? Okay, we can move. Okay. Oh wow, this picture was copied twice. So excuse me. And
Okay. Dr. Linda, sorry to interrupt.
Okay.
I think is that all for today?
Let me be sure.
Okay. Probably we should just maybe stop at that level today, and maybe at our next class, if we have more time, we can show the other ones. I know we've had enough. I mean, we've had a lot rather today. So
okay. Yeah, I think it's the last of it. Yeah.
And I think I heard Dr. Nancy talk about showing more questions in cardio. So put everything in mind, and probably the next section we'll be taking, we'll try to have a longer section. There are some technical issues that happened today. That's why we couldn't start early. So everything will be fixed and corrected for the next section. So we start as early as possible, and we have much time with us to show us the questions. So, Dr. Festus. Chief.
Thank you so much, Dr. Babali. So for those of us that don't know Dr. Babali, that's Dr. Babali for us. So that's our vice president at the Concept Academy. He's a very gentleman. Okay. All right. So that's, by the way, by tomorrow, starting from 5, we are going to have ethics. We didn't put it on the flyer on our timetable because it depends on the availability of the person that's going to be taking us. Okay, before I okay, so it depends on the availability of the person that will be taking us. Not 5 a.m., 5 p.m. in the afternoon, West Africa time. So it's going to be from 5 to like 8 o'clock, 3 hours. Please, if you are going to miss anything, don't miss that at all, like ethics. So don't miss it at all. Like we want everyone to get so used to ethics to the point that we start addressing ourselves in ethical way. We get so it's going to really go a very long way. 5 o'clock p.m. West African time to 8 o'clock. So please never joke with that. So I'm also going to use this opportunity to thank Dr. Efe and Dr. Linda, then Dr. Babawale for putting all these questions together. It's not actually easy to put them together and to take us through them. So we can see the display of knowledge in what they actually did. We are very grateful. Thank you so much, everyone, for also joining. We hope you are actually getting the gist. You are learning, right? Is it becoming simpler day by day?
We wish that this continue a little bit. We're learning.
All right. So